We've been engaging with the Minister for Health for some time now in terms of achieving reforms to the PL that are evidence-based, sustainable, and also ensure that prostheses, through the Prostheses List, continues to actually contribute to the private health insurance value proposition, which it does and which it has done so over quite a period of time. There are a number of different numbers that have been put forward by other stakeholders, and some of those have been, quite frankly, extreme and certainly not based on proper evidence. We've gone through an extensive data collection process with our member companies, and we have a data set that comprises around 80% of the Prostheses List expenditure, and that is the most comprehensive and complete data set that there is. And that's been built up from an actual billing code level. So it has data based on actual product pricing and is able to make that direct comparison for like between the public and private markets. So we're certainly keen to ensure that in the reform process that data is taken into account to ensure that negative consequences in terms of cuts that are too blunt, that are too big, or occur too quickly are minimised, because those consequences could be extreme for both the medtech sector and ultimately for patients. So the IPA data is very useful data for the purposes of which it was designed, which is to identify DRG levels, so diagnosis-related grouping level costs, for the purposes of funding of public hospitals. DRG average data simply doesn't identify specific prostheses costs, and that's acknowledged by IPA and identified as a limitation in terms of this data set. So it cannot be used to identify and make comparisons between public and private pricing on devices. As opposed to the data that MTAA has collected from our members, it is billing code level data, which is comparing like-for-like actual devices within the private and public markets. So the risks of cuts that are too big, too blunt, are significant, and they can include companies having to withdraw from the market, either through withdrawing products or closing their doors because they're no longer viable. It can include reduced access for patients to technology, both existing and new technologies. And it could include that there may be gap payments for patients. Currently, the Prostheses List contributes to the value of private health insurance by ensuring access to technology, and also that is with no gap payments for patients. Minister Hunt is focused on the private sector reform and ensuring the sustainability of private health insurance. And we recognise the important role that private health insurance plays in terms of that delicate balance in our dual system in Australia between public and private health systems. So we're committed to working with the Minister around that, and he's looking to achieve cuts to the Prostheses List in exchange for lower premium increases by private health insurers than would otherwise be the case. We do recognise the need for reform. However, cuts that are too big will significantly impact on the industry. Those claims are simply ridiculous. Those recent announcements were part of a normal process where there can be reclassification of groupings on the Prostheses List. There can be superior clinical performance suffixes that are applied to particular devices on the basis that they have 10 years clinical data that shows superior outcomes for patients, so superior performance of those devices. So those recent adjustments, there were a number of movements up and also down. I think we have to. It's as I mentioned before, private health insurance does play a critical role in terms of the balance between our private and public health systems. So we do need to ensure that the value is put back in private health insurance. What the problem is currently around the Prostheses List is that there is a short-term focus on perceived cost. We need to put the value back into private health insurance and actually recognise that the Prostheses List and medical technology significantly contributes to that value proposition. We shouldn't be trying to achieve a simplistic equal pricing between the private and public markets, because to do so it fails to recognise the fundamental differences between the private and public health systems. So there can be a variety of reasons why there are valid reasons for differential prices. So for example, in the public system, procurement tends to be based on higher volume contracts over a longer term, so that can enable lower costs and therefore lower pricing of devices. So essentially in public hospitals, there's greater volume over a longer period and a limited choice of device. So that's one of the key factors around private health insurance. Consumers buy private health insurance partly for choice and greater choice. Part of that choice is for their treating clinician or surgeon to select the appropriate medical device that is appropriate for the patient's individual clinical circumstances, not just a product off the shelf in the public hospital system.